Okay, good afternoon, everyone. Oh, that was quick. Usually it takes a bit longer for me to keep everyone a bit more quiet. But welcome. Thank you so much for joining us for this very important talk. And so just on behalf of the Division of Public Health Medicine, Healthcare Workers for Palestine, South Africa, and Health Justice Initiative, we all welcome you to this talk. And so what you saw prior to this was a list of names that was scrolling up continuously for about 4 minutes. And for 4 minutes, it was the name of every health worker that's been killed up until now. So that's what those names were. And to give you some context, from the last stats that I have from the 16th of February, it was 340 healthcare workers that have been killed, 356 that have been injured, and more than 100 that have been arrested, many tortured. So with regards to who's hosting, like I said, I'm from Healthcare Workers for Palestine, South Africa. We are an advocacy group that are advocating for the health crisis that is currently unfolding in Palestine. With healthcare workers being targeted and the health infrastructure being targeted and the pending public health crisis that has resulted from that. And so we aim to do that through advocacy and through amplifying voices of other organizations that are basically trying to highlight the same issue and the same plight. And so I just want to very quickly call up Fatima Hassan from Health Justice Initiative to just, in 1 minute, tell us about your organization. Thank you.
So thanks, and really grateful for all of you for making the time in the middle of a genocide, in the middle of ethnic cleansing. And there's a lot of people who have joined us online, so we just want to say thanks to them. I think the recording will also be shared later. Thanks to Healthcare Workers for Palestine. I think Leslie's going to do a vote of thanks. Oh, no. I'm too tall for this. It's fine.
Oh, is that what you need to address?
Okay. Yeah. So I think I first heard Emma speaking, you don't know about this, but at the vigil at Sea Point, it's fine, in Sea Point. And so I'm just really honored and appreciate your voice. I think people are underestimating what it takes for people to be courageous, to speak up. We know, we've grown up in this country, we're all the children and grandchildren of apartheid. And yeah, to have people offer solidarity from as far as Ireland, Canada, Germany, even other parts of Africa, I think is really important. And just kudos to Healthcare Workers for Palestine around the world who are trying to amplify these important voices. You've given some of the stats of people who've died, and I'm sure Emma's going to speak about it, but from where the Health Justice Initiative comes from, is to accept and acknowledge that within this brutal occupation, every single health facility has been attacked by the Israeli military. And what we are witnessing is unprecedented, and I think that word is overused, but we are seeing healthcare being used as a weapon of war. And it's time for more of us to speak up and speak out, and I'm sure Emma will explain and illustrate why that is significant and important. So all I want to urge you today is to go and tell 10 other people about what you heard, what you hear today, what is happening, to call on your professional bodies, professional associations, universities, to condemn what is happening and to support South Africa, not just at the ICJ, but in terms of its efforts for an arms embargo, for trade sanctions, and for a range of other demands that we'll be sharing with you in the next few days. So thank you for being here.
Just very quickly before you start, right? One thing I forgot to mention is that, yes, there is a Healthcare Workers for Palestine, South Africa, but there's also an international group called Health Workers for Palestine that basically has the same objectives to raise awareness, and they're basically an advocacy group. And so this is basically I don't know how many hundreds of healthcare workers around the world that have banded together for a common cause. And so we end up having lots of common, thank you, lots of common events around the world to raise awareness at the same time. So Dr. Emma Keelan is the city lead for North Ireland for Health Workers for Palestine, and I'm the city lead for Cape Town for Health Workers for Palestine. So that's actually how we connected. And I think I'm speaking loud enough, so I don't need the mic yet. But just a little bit about Emma and some background, which is somewhere here. There we go. So yes, we have to do this. Okay. So Dr. Emma is a
Wouldn't really do well with this. Sorry.
when you know, in this case, when you know, right? So Dr. Keelan is a dual-trained medical consultant with certification in both general internal medicine and respiratory medicine, recognized by the General Medical Council. And she holds a master's degree in global health with a distinction from the University of Manchester in the Humanitarian Conflict Research Institute, and has extensive experience delivering healthcare in mobile clinics across the occupied Palestine territories in her role as a volunteer with Physicians for Human Rights. And she's also published her work quite widely in peer-reviewed journals, and you can read about that. But for now, today, she's going to talk to us about her experiences being a physician in the occupied territories.
So thank you so much, Rosa. Thank you for having me. I think the first thing to say is I'm going to take a slightly different approach today. With everybody talking about Gaza, I'm going to talk about the occupied West Bank, and I'm actually going to go back and talk about things that happened before October 7th. So it gives a bit of context. So yeah, I am the city lead for the North of Ireland. We have to say the North of Ireland because we had our own conflict. Some people like to say Northern Ireland. Some people like to say the North of Ireland. So we just write healthcare workers for Palestine, UK, Ireland, and that seems to keep everybody happy. So that's our little logo at the bottom there. So I had one talk written and then completely sort of changed it up based on talks that I've given over the last couple of days in Cape Town. And the first question we've been asked is why Palestine? Why do we? I say we because it's myself and my husband that have been going from 2009. And why Palestine? So this is a picture taken from the occupied east of the city, and it looks down over Jerusalem, and you can see in the middle there the Temple Mount. Palestine it's incredibly beautiful. I went for the first time in 2009. My husband went because a friend was there. He was teaching English, and he ended up traveling from basically Bethlehem to a refugee camp in Ramallah within the space of 12 hours. And his experience changed him. He came back, he said, I'm going to go do a PhD on Palestine. And I said, cool. I don't know where that is. I don't know very much about it. And I have to be really honest, like I really started from the bottom. So I went to visit, and that was in 2008, and it changed my life forever. So I was fifth year medical school whenever I went for the first time. And as I went then back more regularly, several times a year from 2009, because he was doing his PhD and then he was living there, and I went for weeks and weeks at a time. And as a first year doctor in the North of Ireland, I was starting to understand what health meant to me and what health was within the system I was working in. And then I was seeing things that were very, very different. And whenever you start to see things, you can't unsee them. And I think that's the main thing, the main take-home message about Palestine. So all of these pictures are my own. These have all been taken on streets as I've been walking up and down. So these gentlemen were just walking through East Jerusalem. They're settlers. And this is an area called Sheikh Jarrah, which is under attack. So Palestinians are being displaced from their houses in East Jerusalem, and their houses are being taken. And then this is in the old city of East Jerusalem. And when the houses are taken, they're taken violently. Palestinians are violently being expelled from their houses. And then flags go up to demarcate them as then settler houses. So, as I said, I was trying to think, what is health? And to me, health is three things. The first thing, it's a right. Health is a right. But it's also, we say in Ireland, and probably say it in other parts of the world, but health is your wealth. It was Gandhi that said that, you know, it's worth more than silver and worth more than gold. So it's also a privilege, and those that have more privilege tend to have better health. And the other thing, and I think this is where we're getting sticky with things at the minute, is that health is political. And if I have to tell or listen to any more people tell me that health is not political, I am going to absolutely crack up. Because healthcare workers in Ireland, you know, are going into the hospitals to talk about vigils, and we're being told to keep quiet because health isn't political. And it's not that health isn't political, because in the spaces at home at the minute, people are striking. They're talking about striking against the government and going on, you know, an action of civil disobedience about a healthcare system, which is the NHS, which is funded by the UK government, and then going on these acts of civil disobedience. That's political, but it means that people don't want to talk about health politically in relation to Palestine. So we have the luxury to think about health in lots of these different ways. And it is a luxury to be able to think about it like this: lifestyle, rest, sleep, exercise. And I just want you to look at this for the minute, because I'm going to unpick all of the ways that Palestinian health is affected in all of these different ways through the occupation in the West Bank. So I know the room's full of lots of different people with lots of different experiences, but we look at our social determinants of health. And to just, not sure if I have it. Oh no, that did not go well. How do we get back on again? Oh, there we go. Clearly I don't have a little pointer. But we look at things like employment, housing, safety, what else do we have? Hunger, support systems, health coverage, and how these culminate to our health outcomes for morbidity or mortality or life expectancy. What is happening in Palestine is more than just poor health. It's a systematic unpicking of health at absolutely every single level. And at any other kind of, you know, sovereign state throughout the world, we can think of health politically in this way: how things such as, you know, what our governments do, what our governments say, how they make state laws, federal laws, executive orders come to affect the population health. But what is important is that in Palestine, Israel, as the occupying power, retains the responsibility for protecting and fulfilling the right to health. It is up to them to ensure equity and to ensure the fair distribution of resources and non-discrimination when it comes to healthcare for Palestinians. And this is where the political determinants of health then come in. So it was Daniel Dowers in 2020 who started to then refer to things such as the political determinants of health. And essentially what this is, it's the power relationships and the distribution of resources which can adversely exacerbate health inequality or can ensure better health equity. And we'll come back to things such as necropolitics then whenever we sum up at the end. But these are just a few little, I haven't got many words in this presentation, but these are just a few little stats on health. So life expectancy at birth in the occupied Palestinian territories is 75 years of age. In Israel, it's 85 years. Infant mortality under 5s is approximately 50 per 1,000, and it's much higher in refugee camps. 44% of the population is children, and another quarter of the population is between the ages of 18 and 29. Maternal mortality is 4 times higher than in Israeli women, and non-communicable disease is the leading cause of mortality. And I hope that through some of the next slides, you'll be able to see some of the reasons why that is. But as it stands, 25% of the West Bank have refugee status. And prior to October 7th, 70% of Gaza have refugee status. So they were displaced in 1948. And the lived reality for Palestinians is all because of this idea of settler colonialism. And settler colonialism, if we want to think about it in 4 easy ways, could be summarized as expansion, denial, expulsion, and exceptionalism. And these are the 4 kind of frameworks that I'm going to just try and show you how the occupation affects health in the occupied West Bank. Because ultimately what it does is this. So this is a picture from the wall, the apartheid wall. And I think it sums up things very well. Freedom of movement, lack of access to water, lack of equality. You don't get opportunities, you know, to have a lot of these things in Palestine. And we can see, I talked about the wall, but we can see actually that Palestine is disappearing. So this is from 1946. It says today, I made this presentation in 2021 and used this slide, and I had to update it because Palestine is disappearing. And it's disappearing because of Israeli land grabs and because of settler expansion. And these things have an impact on health. And I'm not going to go into politics and things, but what I do want you to know or just to see is that whenever the wall is put into place, for you to move between the wall, this is what it says to Israeli citizens. So this road leads to Area A. Area A is supposed to be administered by the Palestinian Authority, and that is important. So Area A is supposed to be administered by the Palestinian Authority. The Israeli occupation forces should not be in Area A. So this is areas like Nablus, areas like Tukarim, like Bethlehem, like Ramallah. I'm sure you've heard of the Israeli army going into Jenin, to going into Bethlehem, to going into Nablus. So also the picture on the bottom, as you can see, it says you're now going into Area A. And these are election campaign posters for Israeli politicians at the bottom. So this is the separation wall. It's illegal. It was ruled illegal in 2004 under the ICJ. It has gotten bigger, it's gotten longer, it's gotten more militarized since that time. And it's not just about building a wall. You can see a difference between the 2 sides in the photo. The black water towers on one side that don't exist on the other. Palestinians have their access to water affected. 1.4 million Palestinians live with a severe or catastrophic reduction in their water. If you don't have access to clean water, you have issues then with sanitation, you have increased risk to diarrheal disease. It costs money to buy water in Palestine. Every house in Palestine has this on their roof. When we lived in Palestine, we had to buy our water. It then sits in stagnant tanks. It leads to issues. The water is not always clean. You then have to buy bottled water. Bottled water costs money. So these all impact health. And where is the water going? The water is being rerouted to the settlements. As well as that, wells are being attacked. They're being deliberately filled with concrete. The lack of access to water affects agriculture for Palestinian farmers. That affects people's ability then to go to tend to their crops, to make money, which then leads to further poverty, which in turn affects health. This is a picture of the wall from Bethlehem. That's Brennan standing there, so it's not an insignificant, piece of infrastructure. It's massive. You can see on the far side, it's heavily militarized. There are checkpoints everywhere. And also, if you can imagine, just to the left of the photo, this is actually at the point where it split the wall between two brothers' houses. So this was family land, and they put the wall down the middle. So one brother lives on one side and one brother lives on the other. What does this mean? What does this mean in relation to health? Well, one brother now lives in Israel, essentially. So he has access to the Israeli health system. He's considered a Palestinian within 48. If he has a heart attack, he can go to an Israeli hospital and seek healthcare, quite quickly. That will be about 7 kilometers down the road. There's no cardiac unit in Bethlehem. The nearest proper cardiac unit is in Ramallah. For the brother in the West Bank, if he has a heart attack, he now has to try and get an ambulance to take him to Ramallah, which is about 17, 18 kilometers away. And he must now go through checkpoints. He has to go currently through at least 3 if they're open. And that doesn't include the flying checkpoints, which can occur. And he can be turned back at any checkpoint along the way. On a good day, that could take up to about 1 hour and 15 minutes, whereas the brother on the other side could be at a hospital in 15. And time is heart, time is brain, time is your health in a situation like this. And it also costs more money. So if the first brother needs to attend a clinic, it's going to be an awful lot cheaper for him to attend than it is for the brother who's stuck on the other side of the wall. And the other issue you get is in terms of the camps. So this is Ida refugee camp in Bethlehem, and it's surrounded on several sides by the wall with this very kind of narrow entrance. And the design of the camps is, it's deliberate as well. It would take nothing to close off the entrance to the camp. And this happens frequently. Shufat refugee camp was closed for 5 days in 2023. It's home to 30,000 people. And during this time, patients who attend for their dialysis couldn't go. Women couldn't go to give birth. They had to give birth within the camp. These are statistics from the WHO, incidentally. There was somebody with an acute abdomen, so they potentially had a surgical issue. They couldn't get out of the camp. There was somebody with chest pain, couldn't get out of the camp. And there was somebody who was having an epileptic seizure who couldn't get out of the camp. One of the clinics that I frequently go to is in a place called Beta in Nablus. It's in the north, and it's surrounded on 2 sides by settlers and settlements, and 3 sides by settlements, and then on one side it has the checkpoint, and they frequently shut it off. And it's the army go in quite consistently to the area, and it's home to 10,000 people. And the last time I was there in May, they told me that in the previous, since we were there the year before, that 6 women were forced to give birth at the checkpoint, and that 2 of the babies hadn't survived. This happens over and over and over and over again. These are just the stories that I have. And these are what the checkpoints look like. So this is the big checkpoint in Bethlehem. Bethlehem's in Area A, under Palestinian control. This is another checkpoint in East Jerusalem, incidentally outside a convent for nuns. And this is a checkpoint in Hebron. And you can see, if you imagine trying to navigate these spaces, they're violent spaces. Women in particular are subject to sexual harassment at these spaces. They can be asked to remove their hijab as well. And they're also subject to not being allowed through and denied entry. And this is a slightly different checkpoint. So at the point between moving between the West Bank and Israel, you have these larger crossing points. And if you are granted, you have to get permission to come from the West Bank into Israel. If to do that, you have to ask for a permit. About 15% of the West Bank permits are usually denied. And that can include being denied access for cancer treatment. The same principles apply in Gaza as well if there is crossing. And to be honest, usually the permit denials are much higher at Gaza. What actually has to happen is this. So you get one ambulance that takes you from wherever you're coming from in the West Bank. You go to this crossing or another crossing point. Then you have to get out of the ambulance, and then you have to get into a second ambulance from on the Israeli side to then go to the hospital. 93% of ambulances, that 93% of times that happens. So 7% get through from the West Bank directly. And there's delays. So the average delay in transfer time in an emergency is an hour. So that's an hour between getting out of one ambulance, the next ambulance actually being there and moving between. And these spaces aren't, this is actually really quite big. So you're only seeing one side of it. And it could be cold, it could be wet, you're unwell, and you're being pushed along in a trolley. And these can also be closed. So Erez is at the Gaza checkpoint. It was closed for 5 days in 2022. And that meant that there were nearly 900 cancelled medical appointments, and a third of those were for cancer patients. And it goes on. So denial. So the permits we've talked about, but there's also the dual use policy, and this particularly affects cancer patients. So if it's thought that a substance or a piece of equipment could be used in a way that would affect Israel's security, it's not permitted within the West Bank or in Gaza. And the main issue that it pertains to within the West Bank is things like PET scans and radiotherapy. So there's not the same access to these, which is why cancer patients have to travel from the West Bank in the first instance. But also just the general sense, doctors in training, there's no PhD programs that occur medically, to my knowledge, and the last time I did this, in the West Bank. And then the governance. So the Paris Protocol, this is an issue from Oslo, where Oslo has many issues, but this is one in particular, where the PA remains subservient essentially to Israel. So whilst Palestinian is a lower economic kind of area, it is deemed to be essentially the same as Israel in terms of economies. And Israel is a massive economy. And that means then that all of its imports and exports are taxed in the same way. And it's not allowed then to import medications more cheaply like countries in the global south can do. So it can't import from China, it can't import from India. It's completely beholden to Israel for its imports of medication. And this is why I have Teva up here, because Teva is a global Israeli pharmaceutical company, and it's on the boycott list for a reason, because it also has parts of its company within settlements in the West Bank. And the amount of medications then that are available to patients at our clinics is so small in comparison to what I would have at my disposal within the UK. There are no inhalers, for example. I'm a respiratory doctor. There's oral salbutamol. I've never seen oral salbutamol before I went to the West Bank. because it's just not something that we use anymore. We use, there's such limited supplies of insulin, and to buy insulin is so expensive. There's metformin and there's basically glucophage. But within the UK, there are so many other types of medication for type 2 diabetes now, sort of at least 4 different types of pharmaceutical or pharmacokinetical types of drugs. But it's so basic within the West Bank, and they're used at the lowest doses as well for people. And it's because of this, the medication is so expensive. And then you have expulsion. This picture is actually taken from the university. So these are all what were used against the students whenever we worked there. So you can see rubber bullets, shells, tear gas canisters. So whenever I worked in Alcott's medical school, we had incursions into campus. These were at one point in time daily. We had a consistent ambulance on site every single day because our students were being attacked every single day. They would break the windows would get replaced, they would break them again. But the expulsion is in terms of the physical, the physical removal of Palestinian bodies, and the injuries are deliberate. Young boys are targeted, men are targeted, and so many of the injuries are deliberately targeted towards the legs as well. And there's a lot of disability that we would see within the West Bank. And it's hilly. The camps are not designed for people. There's not disability access in a lot of places. The resources in terms of wheelchairs is very limited. They're very old-fashioned. Prosthetic limbs and things are not widely available for people. So if you have an issue and then have an amputation or something like that, it's very, very difficult to then continue to work and employment. And within the West Bank, services such as physiotherapy and things are very limited. And Area C is an area under Israeli control. So these are areas where people are likely to be displaced even more. So in particular, the Bedouin community, which are a group that don't often get talked about. Healthcare Workers for Palestine had a physiotherapist, Allah from Massagat, speak. He is Bedouin, and his stories in particular about how he has grown up in an area outside Hebron as a Bedouin are particularly harrowing. But there's a community of Bedouin just outside East Jerusalem, and they are literally the last group of Palestinians holding the line before Israel completely encircles East Jerusalem. And their access to healthcare is being targeted very, very specifically at the minute. So they're completely reliant on a mobile clinic, which is going in once every 2 weeks. And then you have discriminating planning and policies, houses being taken down, not being allowed to access your land, not being allowed to build on land, having cultivatable land that you can only access maybe once every couple of months. And then there's a rise in settler attacks. These are up 25% in 2023 alone. And again, where you see the flags are houses that have been taken from Palestinian families. And then on the right, this is Mali Adamim, which is one of the largest settlements in all of East Jerusalem. It has its own university. It's that big. And this is what a mobile clinic looks like. And I think you might be surprised. I'll play. Oh. No. Essentially, we set up in schools.
Is it a video that you're trying to play?
Yeah.
Do you have a link to it in your
In there. No, it's just embedded.
didn't put it in your maybe don't play from here? Opening. Do we have any techie people here?
I have it on my computer if anybody wants to come and see afterwards.
Through the browser, not PowerPoint.
It's embedded in.
Copy the link and then open Edge and pen.
Oops.
I'm not sure it's because it's not a link.
Sorry?
Because it's not a link, it's just embedded from my.
Okay, so just hold on. I'm just going to stop sharing for a second, otherwise everyone's going to see my emails, which I forgot to close anyway.
Essentially, we set up in schools in the mobile clinic, and what you can see at the start of the video, just on that picture, is we've pushed together 3 tables. No? I don't think we'll, because it's not it.
Should we leave it
I
there?
think we just leave. I'll happily leave if anybody wants to see it. I have my computer and it'll play on that. Sorry about that.
Okay.
So yeah, these 3 tables that you see, they're pushed together, and that's how we actually have to examine people. Sometimes we have a blanket to put over it, and then we have a table and 2 chairs, and people come in and they rotate through. So whenever I say that the mobile clinic, we do a mobile clinic, it is really, really rudimental. This is not appropriate to examine somebody on, and that this is a lifeline for people, but this is an examination couch, apparently. And these are other pictures of mobile clinics. Yeah. So this structure doesn't look very much like a clinic or a hospital. It didn't have itself any running water, but it was in a Bedouin community near Bethlehem, and we would go there every single week. And in that clinic, we would see at least 50 people. The boxes are all of the medications that we have every time we do a clinic. So once they run out, that's all that we have as well. This leads to particular problems. So if somebody's on a brand of medication for their high blood pressure, and then we run out of that medication, the options are we either use something different just for high blood pressure, or we give them nothing. And you can see in terms of confidentiality, it's not so much of a thing, because there's such a need and people are so desperate that there's a constant flow of people that are coming. So we have this very specific challenges at the mobile clinic. We have the need, hundreds of people, they find out when the clinics are coming in, and then they queue up in the days before. Some are better organised than others. There's the prescribing issue. We have a list of medications that are updated that we have, but as I say, when they run out, we have to find alternatives. There's a compliance issue in general, because so many of these people are reliant on the clinics to come in. We can only also give 2 weeks worth of treatment. So the Palestinian Medical Relief Society have to charge 30 shekels also for the medication, which can be an awful lot of money for some people. Physicians for Human Rights, we are able to give the medication for free. Both clinics, it's for 2 weeks. If people run out after 2 weeks and the clinic's not there, or they can't get, or they have no money, people stop taking their medications. And this means then that's why non-communicable disease is such an issue. If you get 2 weeks worth of high blood pressure medication or diabetes medication, and then you don't have it for several weeks, frequently we're seeing people with the complications of high blood pressure with, CKD as a result of it, or we're finding people, with the complications of their diabetes, and poverty leads so much into that. And because there's so much issues with acuity of health, preventative health is so far down the line. And sometimes we have specific days and specific clinics, such as this one, where we go in specifically to do interventions on preventative health. But to give an example, in terms of women's health, 60% of women don't know how to do a breast exam for breast cancer. And that's why the 5-year breast cancer mortality rate is 40% in Palestine, whereas it's 85% in Israel. So your survival rate is so much lower in Palestine. And that's because 80% of Palestinian women are diagnosed at a metastatic stage. And it's because of so many of these things. And there are particularly vulnerable groups, those with underlying health conditions, those who are women, children, pregnant women, and mental health is a very big issue. This is area A. This is a nighttime raid. And nighttime raids are something that happen very, very frequently. In fact, they're an actual pilot program of the Israeli army. So you have children. So not only is there a statistic that I think 88% of children have seen or experienced somebody close to them being killed, you then have the concern, because children are also being taken in these raids and put in administrative detentions in prisons. Children aren't sleeping, parents aren't sleeping. There's such high levels of stress. And people have asked me a lot when I'm talking about trauma and PTSD. PTSD in Palestine, you know, you can't really be post anything whenever you are continuously being traumatized. And with everybody in society also being continuously traumatized, this kind of biomedical sense of mental health that we apply from the West is also completely inappropriate in this setting. And the sense as well is that with everybody being traumatized, people generally, and in my experience at the clinic, don't like to talk about their mental health, because it's a sense of, well, I've only had 2 sons martyred, but so-and-so down the street has had 4 sons martyred, but I don't live in Gaza, where I've been displaced several times. And the most that people will maybe say is, I have a headache and the headache sits here and I just feel, so it's this sort of psychosomatic presentations that we see a little bit more, but yet people are still very reluctant to, nobody wants a sleeping tablet, or nobody, you know, wants anything further, more willing to accept something for like heartburn related to stress as opposed to anything else. And I'm not going to touch too much on Gaza, but exceptionalism is a thing as well. And whilst all these things aren't necessarily occurring, these are things that have happened. There's been organ harvesting, and there's concerns about how bodies are being taken by the Israeli army presently in Gaza. During COVID, that it vaccinated all of the Palestinians fairly. It meant those in 1948 territories, those in Israel, that was 12%. There's targeting of healthcare workers. This was Rizan. She is a nurse in Gaza in 2018. This is not new. They targeted Jenin in 2023, and it's 403 as of the 23rd of January. And there's been a siege on Gaza. There's been calorie counting on Gaza. These are things that have been said, that Palestinians need less meat, Palestinians need less fruit and vegetables. These things, they don't make sense, but apparently they're there. And I've touched on this. So just to sort of bring things to a conclusion, we talk about apartheid, and I don't need to talk about apartheid to this room, but in terms of the crime of apartheid and what it is, it's about maintaining domination over another. And within medicine, technically at the minute, there is no framework or no formalized what is medical apartheid. We are using this sense of domination in relation to healthcare, but we don't have a framework that says these things specifically are medical apartheid. The phrase was coined in relation to the kind of unequal access of healthcare. Hello. In terms of Black Americans and not being able to get access in the same way. And that's where the initial medical apartheid was used. And it's important to kind of see all of these things and then to see the new issues that are coming. So the aid propaganda, the designation of UNRWA as a terrorist organization, and it's not just UNRWA, it's human rights groups as well. There were several, about 2 years ago that were all designated. These pictures are from the wall whenever Trump was president. You may as well change that to Biden or to Rishi Sunak or any of the current anybody in Europe presently, really. So essentially what I'm trying to say is Palestinians live in a state of managed death from the minute that you're born all the way through in the occupied Palestinian territories. This is really what's happening. And for me, then, the way to frame all this is necropolitics. It's about this idea of the living dead, and that is what Israel are doing, unpicking health until Palestinians really, at no point in time, have a sense of having good health or truly being able to live. And necropolitics, it's Mbembe in 2003 who first coined it, but it's specifically in relation to states of exception, states like Israel, where they say that they need it for to manage their security, to manage threats, and then these things become completely embedded and they're allowed to do it with impunity, and it becomes entrenched then over time. And it's the sort of almost the ideology of necropolitics then that we're seeing with the actual examples of discrimination, of the manifestations of medical apartheid. And what is the solution? So one of these pictures is from Belfast and one of these pictures is from Palestine. And I'll tell you, the one about resistance is from Belfast. So I don't have a solution, but I think there's different things that we need to think about. And I think Palestinians in Palestine have to think about things very differently than we have to think about them here. And the idea that peace is not always welcome, I think is fair. At the start of this conversation, I'm from Belfast, we have peace, but I still don't think certain communities have justice. We still don't have the same level of equity for everybody within our society, which is coming out of violence. And I don't think, I could be wrong, but my assessment of the 2 weeks here is I don't think that there's equity here within healthcare either. And I don't think that's a controversial statement. So, you can have peace, but what we are looking for is justice. And as healthcare workers, justice is a really key component of what we do. It's part of our practice. And the right to health is it's enshrined within law. But the political determinants of health that I talked about at the start, I think this framework gives us here outside of Palestine something different then to look at, because it places advocacy as such, as at the heart of what we can do. And it puts direct action, negotiation, introspection, that things like this and coming together and different forms of solidarity and speaking out. And as Fatima said, if you speak to 10 people and you say, this is 10 more people that know a little bit more about what's happening in Palestine, and we can all be advocates. And I think healthcare workers, public health workers have a very particular role. So finally, this is from the wall again. So with love and kisses, nothing lasts forever. And I think we can all hope that this is where we find ourselves. Thank you very much.
Good presentation.
Wow, Dr. Keelan, thank you so much. Sorry?
I probably rambled, I'm sorry.
No. I think they are very eye-opening ramblings. I recently discovered that there are people who believe that the situation is not this bad.
Yeah.
Like it's an exaggeration what you see in the media, it's an exaggeration what you are reading about. And you know, just to sort of exaggerate as to what's going on. But I mean, most of your talk was about the healthcare system prior to 7th of October. So this is, I mean, basically a medical apartheid that's been ongoing for a long time. So we're going to open the floor for questions. I'm also going to take some, ooh, I forgot, they can't see me. I'm also going to take some online questions as well. So please type your questions in the chat and I will field some of those. Is there anyone on the floor here who would like to ask a question?
Thank you, another wonderful talk, very good. So that was pre-October 7th. Can you give us any insights into, I mean, that must now look like Nirvana, you know, it must have deteriorated so much since then. Can you give us some insight into what's happening now, just 4 months down the line?
So the main issue.
Sorry, can you just repeat the question? Otherwise people online can't.
So the question essentially is how has healthcare in the West Bank, or how has it been affected since October 7th? I unfortunately have not had the opportunity to go back since October 7th because not allowed in. But I've been speaking to my colleagues who are doing the mobile clinics, and what they're saying is that it's increasingly difficult to get access to certain areas because of the increase in settler attacks, but also just in general, the West Bank has been shut down. There are more checkpoints. There are more what's called flying checkpoints, so the ones that just kind of pop up out of nowhere. There used to be about 4 of those a week, and they're basically daily and multiple times a day at the minute. People are reluctant to come out, and the need at the clinic is growing higher because so many people have been made unemployed because of the situation that's happening. Essentially, because the West Bank's been into lockdown, people can't tend to their land, and permits aren't being permitted to the same degree. As that's probably a combination because also the hospitals in Israel are becoming very, very full because of the casualties that they're suffering in Gaza coming back. And they are trying to increase the number of clinics that they're doing because some of the clinics used to run concurrently in the West Bank and in Gaza, but they're not going into Gaza now at the minute. So they have tried to increase, but they're not always able to get to certain areas. So they're concentrating, I think, a little bit more up in the north, and coming in through Israel to do it.
Thank you. Before we take another question, I noticed that the physiotherapist that you spoke about earlier is here. Welcome, Allah. Just stand up and wave to everyone. This is Allah Hadalim. We are actually privileged to have him here today. Allah, can I tell you a story? May I tell you a story? Okay, but I'm not going to tell all of it, right? So Allah fled Palestine a few weeks ago because he was being threatened by the Israeli settlers. And so he's come to basically seek safety in South Africa, and he's talking about his story. What I do want you to very quickly talk about, right, because this dates back to before 7th of October, if you don't mind coming up quickly, is tell us the story of why you became a physiotherapist. Yeah, now, since you are here.
In the Bedouin, so I mentioned you as well. So
That's good.
Yes, Allah is from the Bedouin community that Emma spoke about. So Allah, just stand and face there so that people online can see you.
Hi everyone. I'm Ala Hadalin, 24 years old, from East Bank, from South Hebron. Physical therapist. Also, it's not a choice to be a physical therapist, and also I'm activist. And also, it's not a choice to be activist. and there's no choice in Palestine. I became a physical therapist after my father was suffering from a stroke, and he needed physical therapy sessions, and we wasn't able to take him to the hospitals or the physical therapy centers to take these physical therapy sessions because the checkpoints, because the situation there, because I'm living between 3 settlements actually, and I'm the most close one in the West Bank to the settlement, just 2 meters between me and the settlement. And after also graduation, I'm going to work with some of my friends who are shooting by the Israel's occupation, and they have a quadriplegia, and I work with them because I was happy because I'm helping my community. I've graduated from here and I'm working for my community here. And as I tell you, to be in medical care health worker in Palestine, you are all the time you are a target for the settlers, for the army, for the checkpoint, for everything. And I can tell you from my community also, I have one of my wives, one of my brother wives is get birth in the checkpoint. And all the time I tell her, I joking with them, I tell them you have to tell this guy his name a checkpoint. Yeah. And I decided to leave Palestine because I was activist and I became a target for the settlers because I exposed their crimes there, especially the settlers, violent and unbelievable really there, because they attack everything. They attack animals, they attack human, they attack our fields, everything. And I cannot imagine everything they do there. And they put my name actually in the blacklist for the settlers to kill me. And if it's for me, as Ala, I prefer to stay in Palestine and die in Palestine to leave. But they will take advantage. They're looking for me to attack my family and arrest my brothers. Actually, I have 2 brothers in the jail, and also they're killing my uncle for 2 years. And I have many brothers also in very bad mental situation after they was in the jail. The life is not easy in Palestine. It's all with suffering. I grew up with suffering. I grew up without the basic needs, without electricity, water, homes. I living in tents, caves. And if I tell you my dreams is to have electricity and water and a healthcare clinic in my area, schools. This is my dreams. I'm all the time looking for that, and I promise myself when I leave Palestine, I will continue to talk about Palestine, convey the message of my people, and I will not stop. Even they will kill me or do anything for me. It's okay for Palestine. Everything allowed. I give permission for everything for Palestine. Even my soul, I'm ready to give it for Palestine and for my people. And thank you.
Thank you. Thank you very much for sharing that. Emma, I'm going to call you back up because there's a question online for you. And then also, is there anybody else wants to ask a question? Okay, so the question is, how do you think the state of managed death has exacerbated since the destroying of so many hospitals?
I think the idea of managed death is something that has much more longevity than that. It's, you take away the hospitals, at some point hospitals can be rebuilt, but it's much more nefarious than that, the idea of managed death. You take away absolutely everything. A large time we talk about a hierarchy of needs in the West, the things that we need to function within in life. And that's what's been systematically underpicked or taken away. So if you take away the access to food and you malnourish then a pregnant woman, then the likelihood is that a child will have issues. And then whenever that child can't get access to properly food and water, then they'll have more diarrheal illnesses, they'll have more issues growing up, they'll have potentially stunted growth. The health is, whenever I say managed death, I mean at every point in your life. So then you take away the hospitals, that's kind of the last kicker. But the idea of managed death is much, much more than that. And you take away the hospitals, but also taking away at that point the universities, taking away then the future of healthcare, the future physiotherapists, the future doctors, the future nurses. they've absolutely kind of then destroyed the entire health system, as well as then the managed death of each individual. And that's what I mean by it being incredibly nefarious. But I think they're similar but also separate.
Thank you. Are there any other questions from the floor? Someone?
Hey, can I just shout from here?
You can, I'll repeat the question.
Okay, cool. Hi. The question is more just on, I think, just getting opinion from you and people in terms of the specific topic, necropolitics, medical apartheid. I was wondering how it's received when you give this lecture, okay? Not to people who obviously are here because they want to learn more, but just in general. And the reason why I asked that is specifically asking like, how does one deal with that?
It's a good question.
So I'll give you an explanation. Yeah, but like. So.
Just hold on. I do need you to come up now because I can't summarize all of it.
Yeah.
No, I just. So what I'm asking is, if you just, I, for example, just dropped this poster.
Yeah.
On it for your interest.
Yeah.
Child health advocates, if you'd like to learn about the background of this complex.
Okay. Can I ask what was their complaint?
The use of the word medical apartheid.
Mm-hmm.
I think I'm just tired.
Yeah. Can I?
Sorry.
No.
Repeat the question for those online.
So I think the long story short is medical apartheid has brought complaints. And I think it's interesting because there's no, that's the point, there's no framework for medical apartheid, so it leaves you open. And yet it's so, you could name the same talk healthcare under occupation, but yet occupation is political and health is political. And that's where the whole thing started off, because I got really annoyed with the fact that somebody said we couldn't talk about health, you know, and yet it's inherently political. And I think at this point in time and in relation to Palestine in particular, health and medical apartheid wasn't designed for Palestine, and it has been used in relation, but only the once. And I think there's a certain amount of normalizing that we need to do, and we need to make it so normal to say, well, sorry, apartheid is separateness, and it's just, you know, one group being discriminated by the other. So if we're applying the idea of medical apartheid, then in a sense of, does somebody who lives in 1948 and is really in 1948 have to go through the same systems to get access if they have a heart attack? No. Well, then can you explain to me how that's not apartheid in relation to medicine? Because that's essentially saying exactly the same thing. But I think people at the minute we find are just willing to have an argument about so much. The necropolitics is saying exactly the same thing, and it's probably harsher because you're saying that it's a state of exception. It's allowed to go with complete impunity because nobody has seen it or checked it. And yet I think because people don't necessarily understand that, and you're saying that actually what they're doing over time is is deliberate. You know, it's not something that's been done by accident. There's systematic over time thought to at every single stage do this. But I think people have less issue with it, and that's why I put up both essentially, because it's been a bit subversive in that sense. But yeah, I'm sorry. I'm sorry you got hassled.
I was wondering how you deal with that and how and what your experience has been.
So I'm at home and I haven't called it the same thing. So I've only started calling it this in the last couple of months. And I think moving forward, I think as the ICJ constantly brings cases and they constantly use healthcare in their cases in relation to genocide, like this attack and this attack and this attack, I hope that we'll get a framework for saying medical apartheid, and I hope that we will be a little bit more, comfortable, but also, in the case like with genocide, we were also given that language, and I hope that then they will help give us that language, and maybe that's something that we look to also try and do as a community as well, that we argue for it to be there, or we start using it and normalising it and publishing with it. Because, as I said, at present, the only person that's used it in a publication in relation to Palestine has been 3 Palestinians, and they're now the outliers. But I think that we, in the greater community, in the medical community, should be supporting them in that.
Okay, thank you. I'm just going to take 2 more questions, and then we're going to go to the vote of thanks. Professor Keelan.
Thank you very much. Thank you. That was such a lovely presentation. Not a ramble at all. That's a lot. Thank you. So I'm just listening to this as a health worker, and I'm wondering, if you look at the scale of the horror of it, and I have a curiosity about Israeli health workers in hospitals in Israel. I mean, are they insulating themselves from this? Are they not aware? Are they completely bought into the Zionist propaganda? Are there rumblings? I mean, I find it hard to believe that there isn't somewhere, somebody saying something from within, because we need that also to come from people there. To what extent is Netanyahu's regime suppressing that? I mean, do you have a sense of that from health workers inside?
So the question was about Israeli healthcare workers in terms of solidarity, their solidarities from inside. So I know a few Israeli healthcare workers, and there is within Physicians for Human Rights, sometimes you get Israeli volunteers, healthcare workers who come and help with the mobile clinics. They, pre-October 7th, have always been small in number, and their experience has always been that they are like a liberal minority. And unfortunately, even since pre-October 7th, even some of those that used to go to the clinics have actually completely left the country because they didn't see it as somewhere that even they felt they could be in. There has been publications made by Israeli health care workers in the Lancet, which unfortunately are not along the same sort of solidarity lines. And they're the sort of crux of it was they feel quite victimized. But it's very small, and it's not that it's necessarily being suppressed, but like, you know, there are people there who are anti-Zionist healthcare workers, but unfortunately it is small, and it's tended to be in the older population. Those who would have come to the clinics would have been retired.
Thank you. I just want to very quickly take a question from our online tool. And so, with the ongoing destruction of concrete buildings causing air pollution, aside from the rubble causing major safety issues and its impact on people with lung problems such as asthma and COPD, can you talk a little bit about that?
Yeah, it's interesting as a lung physician doing clinics in Palestine. There's actually not a lot of COPD, in my experience, or certainly not a lot of diagnosed COPD. There would be issues with asthma. In terms of the quality of the air, you know, there's issues with the air quality because of also the tear gas and things like that. I'm not, in terms of a specialist in relation to the destruction of concrete buildings and the air pollution that's going to come from that. There are going to be the long-term issues that that we see. So I don't really have a full answer for that, unfortunately.
No problem. Thank you very much. And I'm sorry we don't have time for any more questions because we've already ran over time. Just to say thank you so much for coming here, starting the conversation, talking to us about your experiences. I'm going to hand over to Professor Leslie Lundy to do the vote of thanks.
Thanks so much, Emma, and thanks to HJI and Healthcare Workers for Palestine. I think we are quite clearly faced with the challenge as health professionals. I think in our own spaces, there was a question online about how do we get the World Medical Association to take a position. Well, I think many of us are in our own spaces, and I'm trying to do something in my own organization, environmental health, and it's hard because people come back to you and say, it's not like that, but we know it is like that. So I think all of us have a job to do. We have to take it into our own spaces. I do want to just close by making quoting one of the people online who made a very important point about othering. And he makes this example 2 years ago, some years back, on the TV, the Israeli Defense Force was forcibly removing settlers. And the settler complained to the camera, saying, they're treating us like Arabs. We said it all because it's all about othering people. It's about distancing people. And Israel likes to think of itself as a democracy and it's very upset, but it's not a democracy. It's never been a democracy, and we're seeing it so clearly now. So I want to end by thanking you all. Next week on the 27th, we'll be having a talk by Yipeng Lee, who's a Canadian public health. He was a Canadian resident. He's a Canadian and was a public health resident, but he was fired from his university, from his position, because he posted on social media, from the river to the sea, Palestine will be free. And he was kicked out of his program. He was subsequently reinstated, but he's not gone back to the program. I think he's currently in Gaza doing support work, but he will be speaking about his experience. And I think it's really important for us to support and express solidarity with health workers who are prepared to take a stand. Because when you take a stand and you're in trouble, you want support from other people. So let's do that. We'll see you next week on the 27th. Look out on social media, and thank you all for coming.
Volume is actually done. We need to.
If you leave it, it goes.
Finished.